Good morning, student. So, today from 10 to 11, we will take a lecture that we will discuss in today's lecture about the diseases of the uveal tract. So, in a last week, we will study about the anatomy of the uveal tract. That is, uveal tissue constitute the middle vascular coat of the eyeball from anterior to the posterior, and it can be divided into three parts, that is namely iris, ciliary body and choroid. However, the entire uveal tract is developmentally and structurally, functionally are individual, indivisible structures. So, this is about the anatomy of the uveal tract, which consists of the iris, then ciliary body and choroid. Okay, this is a conjunctiva, this is ora serrata, this is aqueous. So iris divide anterior chamber and the posterior chamber. This is a cornea. The aperture in between the two iris is called as a pupil. This is a lens. This is canal of Schellmann. This red color is a vitreous. This is a sclera, and this is yellow line. This is a choroid. Just under the choroid, there is a retina and macula, and this is the central retinal artery and vein with the optic nerve. And this is the rectus medialis which support the eyeball. So the iris is the anterior most part of the uveal tract, and it is a thin circular disc corresponding to a diaphragm of a camera. It is a center and aperture of about 4 mm diameter, that is pupil, which regulate the amount of the light reaching the retina. And at the periphery, the iris is attached to the middle of the anterior surface of ciliary body. It divides the space between the corona and lens into the anterior and posterior chamber. So, macroscopic appearance of the anterior surface of the iris shows the two zones, that is pupillary zone and the ciliary zone. In the pupillary zone, there is a pigment film, collaterate, crypts, contraction furrow, contraction furrow, and the peripheral crypts. Ciliary body is a forward continuation of the choroid at the ora serrata. In a cut section, it is a triangular in shape, and the anterior side of the triangle form the part of the angle of anterior and posterior chamber. In its middle, the iris is attached. The outer side of the triangle lies against the sclera with a suprachoroidal space in between. So, the inner side of the triangle is divided into the two parts. The anterior part is about 2 mm, having a finger-like ciliary process, is called as a pars placata, and the posterior smooth part about the 4 mm is called as a pars plana. Anterior is pars placata and posterior is a pars plana. This is a part of the ciliary body. Then microscopic structure of the iris and ciliary body shows in this iris there is a dilated pupillae, then this is the sphincter pupillae, this is the anterior limiting layer, then this one is the stroma, below that there is an anterior epithelial layer, and just below that there is a posterior epithelial layer. This is a lens, this is a cornea, sclera and ciliary muscle and ciliary body. This whole part is a ciliary body which consists of the internal limiting membrane, then non-pigmented epithelium, pigmented epithelium, stroma, and supraciliary lamina. So, the choroid is the posterior-most part of the vascular cord of the eyeball, and it extends from optic disc to the ora serrata. Its inner surface is a smooth, brown, and lies in contact with the pigment epithelium of the retina, and the outer surface is rough and lies in contact with the sclera. So, this is a microscopic structure of the choroid which contain pigment epithelium, bruch membrane, choriocapillaries, medium vessels, large vessels, suprachoroidal lamina, and the sclera. Then, congenital anomalies of the uveal tract. First one is the heterochromia of iris. It refers to the variation in the iris color and is a common congenital anomaly. So, in the heterochromia, iridium color of one iris differ from the other. Sometimes one sector of iris may differ from the remainder of iris. Such a condition is called as the heterochromia iris. Congenital heterochromia must be differentiated from the acquired heterochromia seen in a heterochromic cystitis, siderosis, and malignant melanoma of iris. Correctopia. It refers to abnormally eccentric placed pupil and normally pupil is placed slightly nasal to the center. Polychoria. In this condition, there are more than one pupil. Fourth one is a congenital aniridia. It refers to the congenital absence of the iris, that is true aniridia, that is the complete absence of the iris is extremely rare. And usually the peripheral rim of the iris is present and this condition is called as the clinical aniridia. So zonules of the lens and ciliary processes are often visible. The condition is usually familial and may be associated with the glaucoma due to the angle anomalies. Then persistent pupillary membrane. It represents the remnant of the vascular sheath of the lens and it is characterized by the stellate-shaped shred of the pigmented tissue coming from anterior surface of the iris that is attached at the collaterals and these float freely in the anterior chamber or may be attached to the anterior surface of the lens. Then congenital coloboma of the uveal tract. Congenital coloboma, that is the absence of the tissue of iris, ciliary body and choroid may be seen in association or independently. Coloboma may be typical or atypical. Typical coloboma of iris and this is a coloboma of a choroid. Typical coloboma is seen in the inferonasal quadrant and occur due to the defective closure of the embryonic fissure. An atypical coloboma is occasionally found in other positions. Complete coloboma extends from pupil to the optic nerve with a sector-shaped gap occupying about one-eighth of circumference of the retina, choroid, ciliary body, iris, and causing a corresponding indentation of the lens, where the zonular fibers are visible. Then the uveitis. So the term uveitis strictly means the inflammation of the uveal tissue only. However, practically there is always some associated inflammation of the adjacent structure such as retina, vitreous, sclera and cornea. Due to the close relationship of the anatomically distinct part of the uveal tract, the inflammatory process usually tend to involve the uvea as a whole. Classification. First one is the anatomical classification. In that, first is the anterior uveitis. It is the inflammation of uveal tissue from iris up to the pars spicata of ciliary body. It may be subdivided into iritis, in which inflammation predominantly affects the iris, and iridocyclitis, in which iris and pars placata part of a ciliary body are equally involved, and cyclitis, in which pars placata part of the ciliary body is predominantly affected. Then second is the intermediate uveitis. It includes the inflammation of the pars plana and peripheral part of the retina. An underlying choroid is also called as the pars plana. Third one is the posterior uveitis. It refers to the inflammation of the choroid, that is choroiditis. Always there is associated inflammation of retina, and hence the term chorioretinitis is used. Then panuveitis. It is the inflammation of the whole uvea. Clinical classification. First is acute uveitis. It has got a sudden symptomatic onset and the disease lasts for about 6 weeks to 3 months. 2. That is chronic uveitis. It frequently has an insidious and asymptomatic onset, and it persists longer than 3 months to even years and is usually diagnosed when it causes a defective vision. Third one is a pathological classification. Suppurative or purulent uveitis. Second is a non-suppurative uveitis. It has been further subdivided into the two groups, that is Woods classification. In that, first is a non-granulomatous uveitis and second is a granulomatous uveitis. Fourth is a etiological, that is the Duke's elder classification. In that, first is a infective uveitis, second is a allergic uveitis, third is a toxic uveitis, fourth is a traumatic uveitis, fifth is a uveitis associated with non-infective systemic diseases, sixth is a idiopathic uveitis. First, that is infective uveitis. In this, inflammation of the uveal tissue is induced by invasion of the organism, and uveal infection may be exogenous, secondary, or endogenous. Exogenous infection, wherein the infective organism directly gain entrance into the eye from outside, and it can occur following penetrating injuries, perforation of corneal ulcer, and post-operatively after the intraocular operation. Second is a secondary infection of the uvea occur by the spread of the infection from neighboring structure, for example, acute purulent conjunctivitis due to the pneumococcal and gonococcal, keratitis, scleritis, retinitis, orbital cellulitis, and orbital thrombophlebitis. Then third one is the endogenous infection are caused by the entrance of the organism from some source situated elsewhere in the body by the way of the bloodstream. An endogenous infection play important role in the inflammation of the uvea. Then types of the infectious uveitis. Depending upon the causative organism, the infectious uveitis may be classified as follows. In that, first is a bacterial infection. This may be granulomatous, for example, tubercular, nephritic, syphilitic, brucellosis, or pyogens such as the streptococci, staphylococci, pneumococci, and gonorrhea. Second is a viral infection, which is associated with the uveitis are herpes simplex, herpes zoster, and the cytomegaloinfluenza virus, that is CMV. Third is a fungal uveitis, is rare and may accompany a systematic aspergillosis, candidiasis, and blastomycosis. It also includes the presumed ocular diagnosis. What happened? Any problem, student? Hello, student. Do you have any problem? Shall I continue lecture? So the fungal uveitis include a presumed ocular histoplasmosis syndrome. Fourth is the parasitic uveitis. Is known in toxoplasmosis, toxocariasis, onchocerciasis, and amoebiasis. Fifth is the rickettsial uveitis. It may occur in scrub typhus and epidemic typhus. Second is allergic hypersensitive linked uveitis. It is commonest. In that, there is a microbial allergy, anaphylactic uveitis, atopic uveitis, autoimmune uveitis, and HLA associated uveitis. Third one is a toxic uveitis. In that, there is a endotoxins and endoocular toxins and exogenous. Fourth one is the traumatic uveitis. So it is oftenly seen in accidental or operative injury to the uveal tissue. Direct mechanical effect of the trauma in that irritative effect of the blood product after intraocular hemorrhage, that is the hemophthalmitis, microbial invasion, and chemical effect of the retained intraocular foreign body and sympathetic ophthalmia in the other. Fifth is a uveitis associated with non-infective systemic diseases. Certain systemic diseases frequently complicated by uveitis include sarcoidosis, collagen-related diseases, that is polyarteritis nodosa, TAN, disseminated lupus erythematosus, that is DLE, rheumatic and rheumatoid arthritis, metabolic diseases, that is diabetic mellitus and gout, and disease of the central nervous system, for example, disseminated sclerosis, and the diseases of the skin, that is the psoriasis, lichen planus, and erythema nodosum, that is pemphigus, and so. Idiopathic uveitis. It may be specific or non-specific. First one is the idiopathic specific uveitis entities include the conditions which have a certain special characteristics of their own. For example, pars planitis, sympathetic ophthalmitis, and which is heterochromic iridocyclitis. Second is the non-specific idiopathic uveitis entities include the condition which do not belong to any of the known etiological group. About more than 25% cases of uveitis fall in this group. Then the symptoms of the uveitis. Symptoms of uveitis contain the pain, redness, photophobia and blepharospasm, lacrimation and defective vision. So there are mainly the symptoms that is pain, redness, photophobia, blepharospasm, lacrimation and the defective vision. And signs that we can see in a patient, that is lid edema, then circumcorneal congestion. Corneal signs include a corneal edema, keratic precipitates, and the posterior corneal opacity. Fourth is the anterior chamber sign. In that, first one is the aqueous cell. It is an early feature of iridocyclitis and graded as a minus, that is a 0 cells, plus and minus, that is 1 to 5 cells. 1 plus is 6 to 10 cells, plus 2 is 11 to 20 cells, plus 3 is 21 to 50 cells, and plus 4 over the 50 cells. So this is the aqueous cell, that is the anterior chamber sign, and it is an early feature of iridocyclitis. Second is the aqueous flare. It is due to the leakage of protein particle into the aqueous humor from damaged blood vessels. When the blood vessels are damaged, there is a leakage of protein particle into the aqueous humor from a damaged blood vessel. So, grades are as follows. that 0 shows no aqueous flare, +1 shows there is a just detectable, +2 is for the moderate flare with a clear iris details, +3 is for a marked flare, that is iris details not clear, and +4 it is for the intense flare, that is fixed coagulated aqueous with considerable fight. So this is the aqueous flare, that is leakage of the protein particle into the aqueous humor from the damaged blood vessel. In that hypopyon vein exudates are heavy and thick and they settle down in a lower part of the anterior chamber as hypopyon, that is sterile pus in the anterior chamber. So hypopyon is exudate are heavy and thick and when they are settled in the lower part of the anterior chamber as hypopyon, it is sterile pus in the anterior chamber. Then hyphema, that is blood in the anterior chamber. It may be seen in the hemorrhagic type of the uveitis. So in the hemorrhagic type of uveitis, there is a blood in the anterior chamber is seen. Then changes in the depth and shape of the anterior chamber may occur due to the synaptic formation. Sixth one is changes in the angle of the anterior chamber and are observed with a gonioscopic examination. In active stage, cellular deposits and in chronic stage, there is a peripheral anterior synapse may be seen. Iris side. In that there is a loss of normal pattern, changes in iris color, iris nodules and posterior synapse are seen. So, in the sign and symptom of uveitis, firstly there is a pain, redness, photophobia, blepharospasm, lacrimation and defective vision is seen, and then lid edema, circumcorneal congestion, and in corneal sign there is corneal edema, keratic precipitate, posterior corneal opacities, anterior chamber sign, that is aqueous cell and aqueous flare, and hypopyon, hypemia, changes in the depth and shape of anterior chamber, changes in the angle of the anterior chamber, and iris sign, that is loss of normal pattern, changes in iris color, iris nodule and posterior synapse are seen. So this is a diagrammatic depiction of iris nodules in the A diagram. And in the B, we can see a clinical photograph showing a Coppens nodule at the pupillary margin in a patient with sarcoidosis. So, this is a because Busaka nodule and this is a Coppens nodule. So, these are the nodule formation in the patient with sarcoidosis. Sixth is a pupillary site. Narrow pupil, then irregular pupil shape, ectropion pupillae, that is eversion of pupillary margin, pupillary reaction becomes sluggish, and occlusio pupillae are the pupillary signs seen in the uveitis. Then changes in the lens. First is the pigment dispersal, exudate, complicated cataract may develop as a complication of periosteum iridocyclosis. These are the changes seen in a lens. Then change in the vitreous. Anterior vitreous may show exudate and inflammatory cell after an attack of acute iridocyclitis. So these are the changes in the vitreous is seen along with the changes in the lens, and there are many pupillary signs. Next is a complication and sequelae. So the complication of uveitis it lead to the complication that is complicated cataract, secondary glaucoma, in that early glaucoma and late glaucoma in iridocyclitis. Then third is a cyclitic membrane. Fourth is a choroiditis. Fifth is a retinal complication. Sixth is a papillitis, that is inflammation of optic disc. Seven is a band-shaped keratopathy, and eight it is phthisis. Then the differential diagnosis of uveitis, that uveitis is differentiated from the acute red eye granulomatous versus non-granulomatous uveitis. Etiological differential diagnosis and investigation, in that there is a hematological investigation are needed, that is TLC, total leukocyte count, and DLC, that is differential leukocyte count, to have a general information about the inflammatory response of the body. ESR to ascertain existence of any chronic inflammatory condition in the body. Blood sugar level to rule out the diabetes mellitus. Then blood uric acid in a patient suspected for having gout. In the gout there is increased uric acid. In diabetic there is increased sugar level. Serological test for syphilis, toxoplasmosis and histoplasmosis. So for serological test, syphilis, toxoplasmosis and histoplasmosis, serological tests are needed. Test for the anti-nuclear antibody, that is Rh factor, E cell, C reactive protein and anti-trypso lysine 0. These are the tests for the anti-nuclear antibodies. Then second is a urine examination for WBCs, first cell, RBC and culture to rule out the urinary tract infection. So urine examination is also needed to the diagnosis of uveitis. For